formally by the recitation of Holy Quran. So I request Mr. Saad to please recite few verses from the Quran Kareem.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم لله ما في السماوات وما في الأرض وإن تبدوا ما في أنفسكم أو تخفوه يحاسبكم به الله فيغفر لمن يشاء ويعذب من يشاء والله على كل شيء قدير آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين أنت مولانا فانصرنا على القوم الكافرين أنت مولانا فانصرنا على القوم الكافرين.
Jazakallah. Over to you, Dr. Amir.
Thank you, sir. This program has lectures, and to make it interactive, we have case discussions as well. And at the end of the discussions, we have a questioning and pool to aware of what the understandings we develop after this webinar. So, being a Vice President of Pakistan Orthopaedic Association, I am thankful to all of the eminent faculty who join us from all over the Pakistan to spare their time to teach us in this pelvic and acetabulum forum. Thank you. And this is the live program which will be recorded as well. Anyone from the participants who wants to ask the questions, they will write their questions in the chat box or raise their hands. So thank you, and I will hand over my mic to Dr. Nasir to please continue the program. Nasir, mic on, correct?
Thank you very much, Dr. Amir, and I welcome all the participants. And I think without wasting further time, we'll move on to the presentations. And the first presentation is by our worthy faculty, Dr. Masood Umar. Sir, I would request you to kindly share your screen and start your presentation.
जी अस्सलाम वालेकुम बिस्मिल्लाहिर रहमानिर रहीम अल्लाहुम्मा सल्ली अला सय्यिदिना मौलाना मुहम्मदिन व आलिहि व बारिक व सल्लिम अलैहि। साथ ये कह रहे हैं कि होस्ट डिसेबल्ड पार्टिसिपेंट स्क्रीन शेयरिंग।
Sir, you can allow to do that. Please retry.
अच्छा जी, नासिर साहब स्क्रीन नज़र आ रही है?
जी बिल्कुल नज़र आ रही है सर, क्लियरली नज़र आ रही है।
Acha ji, Bismillah Rahman Rahim again, and thank you for inviting me in this webinar, Pelvic and Acetabular Surgery, and the forum has been a passion for me since last 10-15 years, and without taking much of your time, I would start. Topic given to me is pelvic fracture classification, and it has been really a long time I dwelled on this topic, but anyhow I'll try my best. So what I use is Young and Burgess, though there are many classification systems you would find in the literature, but I guess Nasir Sahab, I have 7 minutes, is that right?
Ji sir, then we will have 4 minutes for discussion, question, answers.
Yes, so actually, this is a very familiar picture I borrowed from Dr. Hanif's presentation. Thank you, Dr. Hanif. Polo tablet, which depicts a pelvic ring, and any break in the ring, you should try to find that there has to be another break somewhere else for the tablet to displace. So this is a simile drawn for the pelvic ring. If it breaks anteriorly, you have to look very carefully for a posterior break, and this happens but very rarely that there is only an anterior break. So just like you cannot break the polo tablet by only bringing a fracture at one point, unless it breaks at 2 points you won't be able to displace it. So same holds for the pelvis, and as we have learned over the years, CT scan, as it has come into vogue now, has made things very clear and sharper for us. But what you need to develop as students of pelvic and acetabular surgery is a very sharp eye to have a grasp on the plain AP X-ray, which you can be helped by inlet and outlet views. So much so for the breakage part. Any classification system should aid us in predicting hemodynamics instability. So classification has to have its reasons and predictions, prognostications, predictability. So any classification which has all of these would be a much better classification. So it should be able to predict visceral injury, instability, and we should also be able to incorporate mechanism of injury, vectors of injury, and even surgical planning within that classification. So that makes an all comprehensive classification. So various classifications, as I mentioned, have been proposed, but I, for the past 15-20 years that I've been practicing, have only used Young and Burgess. So in the interest of time, and as Nasir Saab said, we have limited time, we would just skip. If we have time, we would come back, we would skip to Young and Burgess, although I can take you through tile and AO, but let us for the moment come directly to Young and Burgess. So the advantages stated at the time in 1986 when it was presented for the first time was that it increases clinicians' ability to diagnose missed lesions, its predictive index of associated injuries was high, it helped clinicians to select treatment based on probable pathology and hemodynamic status. It is divided into three, as you all know: lateral compression, anterior posterior compression, and then vertical shear. LC meaning LC is lateral compression, and then LC 1, 2 and 3. So I'm just going to very basic level of information now. So anterosuperior inferior rami or symphysis or compression of sacrum on one side, right? So I will show you picture which is better description. This is an LC1 injury in which you just have a compression injury of the sacrum at the back, which is usually missed, and what you only follow is a push from the side, breaking the rami, ipsilateral rami superior inferior. This is classical LC1 injury. Somebody is pushed from the side, or somebody falls on the side and lands on the pelvis. So how it would appear on the X-ray, on the CT. LC2, moving on, so depending on the direction and then force energy imparted to the pelvis, LC2 would imply a greater injury posteriorly, which usually presents as a sacroiliac fracture dislocation that is also called crescent fracture. Obviously there is always an anterior injury in the form of break of the superior inferior rami ipsilaterally. This is how it would appear on the 3D CT. So there is actually a fracture of the iliac wing and a dislocation of the SI joint happening at the same time, hence called fracture dislocation of the SI joint. Just an example of fixation. Now LC3, now continuing on the amount of energy and direction of injury. This is very similar to a windswept pelvis, where injury happens to both hemipelvises. One goes into internal rotation and the other goes into external rotation on the contralateral side. So if there is an accident, something hitting on the right side, the energy continues, the right side is bent internally and the left side goes outward or in external rotation, as is shown in this diagram. So energy coming from your left, producing an internal rotation deformity of the right hemipelvis, and exiting from the right, producing an external rotation deformity of the left hemipelvis. And the associated bony injuries and ligamentous injuries are as shown. So again, it can also come through the pubic symphysis, producing complete symphysial diastasis, but still remaining behaving and remaining like a lateral compression injury because of the direction of force and the subsequent injuries that appear on the X-ray. Further to LC injuries are APC injuries, which are called anterior-posterior compression, dictated by the mechanism of injury, something hitting the patient from the front or the back when the front is stable, or from the front when the back is stable. For example, something hitting you when you are against a wall from the front, any vehicle or anything right in the pubic or pelvic area. So there is diastasis anteriorly through pubic symphysis or a vertical rami fracture, and then usually posteriorly SI joint disruption. APC 1 and 2 and 3 are then dictated by the amount of displacement at the symphysis, which is initially in APC 1 very minimal and is a very stable injury, where there may be mild external rotation of hemipelvis, as is shown here. There is some ligament stretching, and there may be some opening of anterior SI joint, but then again it's a stable injury. APC2 is further amount of injury where there is further disruption of the ligaments, and anterior SI joint ligaments are completely disrupted, so are the sacrotuberous sacrospinous ligaments, as is shown in this diagram. There is symphysial disruption, but the only thing intact is posterior SI ligaments, which make the pelvis hinge on the posterior SI ligaments. So making it at an intermediate grade of stability. It's an example where you would have anterior disruption of the symphysis and moderate opening of the SI joint, but not a complete disruption. But definitely there is sacrotuberous and sacrospinous ligament disruption. Another example, the inlet view and a CT scan. The posterior impaction clearly shows that probably posterior ligaments of the SI joint on the right side are intact and usually treated by anterior fixation alone because the posterior hinge is intact. APC3 again, injury continues further and disrupts the posterior SI ligaments, which is the strongest ligament in the whole of the pelvis. And if we go into anatomy, there are multiple long and short posterior SI ligaments and transverse and vertical SI ligaments. So all of them, and interosseous SI ligaments, all of them are disrupted. Now the hemipelvis is totally disrupted, disassociated from the rest of the pelvis, as is shown here. And last in this classification is a vertical shear, dictated again by the mechanism of injury. So you have to understand APC3 may not appear very different from a vertical shear injury because the only difference is the mechanism of injury. A fall from a height, sometimes suicidal attempt, sometimes murder attempts, patient being pushed from first floor, second floor, or even higher. They land on their calcaneus or lower limbs, and then you have a variable pattern of injury which can include a VS or vertical shear injury. They are always unstable and there is significant vertical displacement of the pelvis. And combine, obviously this is book picture. The picture in reality is always different and a combination of injuries coming from one or the either side. So hence the term was introduced as combined, where vectors can combine. You can have combination of these injuries, APC versus VS or an LC versus VS. As is shown here, you have lateral compression. In terms of sacral impaction, you have VS or a APC in terms of SI joint disruption. Just to introduce very new classification system by World Society of Emergency Surgery, where they combined, I'm sorry for the dull slide, but I just copied from the article. So इन्होंने क्या किया है कि minor, moderate और severe. देखें जैसे मैंने पहले कहा, classification system has to entail a lot of things, and Young and Burgess, I still think encased many combinations, especially the direction of injury and then the treatment pattern. So they enhanced it and they included hemodynamic stability, mechanical stability and CT scan findings, right? And then first line treatment. So all of them they combined horizontally and dictated their classification system, which is called WSES, which is World Society of Emergency Surgery Pelvic Injury Classification System. So minor, moderate and severe according to, then they added Young and Burgess in minor, APC1, LC1, and then the rest in moderate. Severe can entail any of these combinations. Patient is stable in the minor and moderate and unstable hemodynamically in the severe WSES classification system. And then again mechanical stability is only there in minor. In moderate, the patient is hemodynamically stable but mechanically unstable. And then the treatment findings, treatment line is dictated by this classification, where minor classification patients may not require big time treatment, but for first line treatment in moderate you would require pelvic binder, you may require angioembolization, and then in the severe classification you may opt for a preperitoneal pelvic packing or immediate mechanical fixation plus minus angioembolization. So I thought this may be a value addition to the original Young and Burgess classification. I would just stop here and would entertain any questions that may be there. Thank you.
Thank you very much, Jazakallah, Mr. Umar. And in the interest of time, I would request Dr. Ahmed to quickly go through his presentation. And for question and answer, we will be taking question and answer in the chat box or in the question answer box. So Dr. Amir, um,
I don't think there is any question regarding this talk. So we can move further. If any questions arise, we will ask in the end.
we'll ask Saad to kindly upload Dr. Amir's presentation, please.
Sure, I will. Hope you have seen the presentation. Okay, Dr. Amar, over to you. You can speak and I will move on this presentation.
Bismillahirrahmanirrahim. My name is Dr. Amir Ali Shah. I am consultant orthopedics at Shaheed Benazir Bhutto Institute of Trauma. Next. Next, please, Saad. Next, please. So today my presentation is the radiological assessment of pelvic ring fractures. So the osseous and the ligamentous component of the pelvis causes its biomechanical function as a ring, and disruption of one portion of the pelvic ring must raise suspicion for disruption in the second location. It is critical to adhere to the systemic and the rigorous approach in evaluating the pelvic images. Next, please. Next, please. So go back, please. Anterior posterior X-rays of the pelvis should be included in initial radiographic examinations of patients with blunt trauma. The pelvis has a remarkable ability to recoil to a near normal alignment after trauma. This elastic recoil can mask severe instability that prompts further investigations of the pelvis with inlet and outlet views. Next. The AP radiograph shows the key counter contour lines for evaluating the pelvis. These lines are the iliopectineal lines that can be seen as a red line, and then there are ilioischial line, the anterior rim, the posterior rim, the Shanton lines, the teardrop, obturator, and the sacral arcs. The AP radiograph are helpful for assessing the pelvic symmetry and anterior ring, iliac wing, and transverse process fracture. Next. So the inlet films. The inlet view is obtained by tilting the radiograph beam approximately 40 degrees. So the correct inlet view will be obtained if the sacral promontory overlaps the anterior cortex of the body of the first sacral vertebra. The X-ray demonstrates the subtle fractures of the sacrum, front to back displacements of injured portions of the ring, and rotational displacement of injured hemipelvis, widening of the sacroiliac and symphysis pubic joint, and fracture of the pubic remiz. Next. So this is the illustration where the patient is lying supine on an X-ray table, and the X-ray beam has been angled, propelled at 40 degrees. And below that, you can see that what is the actual position that we will achieve on an X-ray film of the pelvis. Next. This is the actual radiographic film of pelvic inlet view. Next, please. One back, please. The outlet view is obtained by tilting the radiographic beam approximately 45 degrees quadrate. Adequate tilt is seen when the top of the symphysis pubis is at the level of second sacral body. Demonstrates the wedge-shaped appearance of the sacrum when viewed from the front. The outlet view demonstrates the fracture of the sacrum, the posterior iliac wing, the fracture of the pubic rami, the widening of the sacroiliac joint, and the vertical displacement of the injured hemipelvis. Next. So this is again the illustration and showing that how the beam has been projected over the patient in a chordate manner. And this is how the pelvis will going to be shown on the X-ray films when we take the outlet view correctly. Next, please. This is the actual film of the X-ray film showing the pelvic outlet view. Next. So the CT scan is now of a greater importance because it gives us a very much detailed about the fracture patterns and a different in different dimensions. So we can have coronal, sagittal, and axial views, as well as the 3D reconstruction that make us more comfortable in planning the management of complex pelvic injuries. Next, please. So the pelvic ring injuries, the pelvic ring, it will be deformed through either fractures of the innominate bone or the sacrum, or disruption or dislocation of the pubis or sacroiliac joint. Most pelvic ring injuries include the fractures and dislocations of both anterior and posterior structures. Next. So assessing the pelvic ring injuries, the pelvic stability depends on the integrity of the combination of bones and ligament. The stable fracture withstands normal physiological loading without significant displacement over time, whereas the unstable fracture tends to displace. Next. To understand the pattern, the pelvic injury have two dominant patterns of displacement: opening and closing of pelvis as a result of rotational forces. Next. And the sepal displacement as a result of vertical forces transmitted to the pelvis by axial loading from the lower extremities. Next, please. One back. Other secondary signs of instability are avulsion fractures of sacrospinous, iliolumbar ligaments, L5 transverse process, avulsion fractures indicating that the pelvis was more significantly displaced at the time of injury. So, as the esteemed Professor Masood Umar has already mentioned quite nicely about the classification. So my presentation might going to overlap almost completely with his presentation. So in the interest of saving the time, I will end my presentation over here, because the later part of my presentation has already been discussed by Masood Umar Saab in detail. Thank you very much.
Thank you very much, Dr. Amir. Over to you, Dr. Nasir.
Thank you very much. Thank you very much, Amir, that you have gotten your presentation. Now the next presentation is by Dr. Kazim Rahim. And I will request Dr. Kazim to kindly upload his presentation and share with us his thoughts.
Assalamu alaikum, everyone.
Alaikum assalam.
First of all, thank you to Saad to upgrade me to the faculty position. Previously, I was looking to be shared as a faculty. So, without wasting any time, can everyone see my presentation?
Yes, very clearly.
First of all, thank you very much for giving me this opportunity to give my talk. My talk will be basically on the emergency management of pelvic trauma. So, starting with this, thus we all need to know how to manage or how to resuscitate a patient with a pelvic trauma. What's important in it? Like in the patient might present it to us in the OPD or in the emergency with might a femur fracture or like a simple fracture. So it's like pelvic fracture, patient need to be given extra attention, or they need to resuscitate better as compared to the other patient. So how to, before going to my main presentation, we have to understand this is the three phase of when the patient have a severe trauma. This is the first peak immediate. Those patients which having a severe injury, and those patients will not going to survive. They will going to die at the same spot. Then come the second type of patient. They have been injured badly, but still there is a chance that we can save them, and that is known as a golden hour of care. And that's how we have to manage this patient, to give them early best resuscitation and management for their trauma so that they can be saved. If we were not able to do anything good in that first golden hour, then they will going to end up in the third late phase, in which the patient is going to be having a sepsis and the MODS. So the first golden hour is the best or most important time for a trauma and orthopedic surgeon to do his best to save the patient with a severe injury. So these pelvic trauma should be always addressed as a polytrauma, because these mostly have associated other injuries. So there is not a consensus about what the by the definition of polytrauma. So if we see in the literature, there's a lot of definition about the polytrauma, and one says more than two significant injury in more than two body regions. So this is one we off for the polytrauma patient definition for it, and there's other definition in which it has more than two in at least two body region. This is being labeled as a polytrauma. What about these patients with the pelvis trauma injury? Their overall mortality is 5 to 16%, which is high. And if there is an open pelvic fracture with fracture, this goes to 45%. Like half of the patient died if they have open pelvic fracture. But if you see that attributed only to the pelvis trauma is only 0.4 to 0.8%. This shows these patients with the pelvic trauma, they have associated other injuries to the other organ of the body that may be abdominal, then maybe thorax, spine. So one of this about this patient with the pelvic trauma, mostly they can be life-threatening because of the bleeding or hypotensive shock due to the bleeding. And mostly this is venous in origin. It's around 80 to 90%, and arterial is only 10%. That's very important. We all have to understand. Mostly it is venous origin. And these patients have this intra-abdominal injuries like liver, spleen, and ball, 16.5, which is even high. Bladder urethral 3.4, and nerve injuries 10 to 15% because of the pelvic ring disruption, mostly posterior pelvic ring disruption, and thoracic aorta rupture in 1.4% of the patient. This shows this pelvic trauma patient have associated injuries, so this need to be addressed as a polytrauma. So why this happen? What is the vicious circle in which this patient goes and then they have this death? This is known as a circle of death or triad of death, in which patient enter, once a patient enter into one of the three, and they goes into second and goes third, and this is how he will end up with death. So we have to prevent the patient from reaching to that level. So what we all know and what we all do in the patient with the severe trauma, we follow ATLS protocol. So we all know about it. So I will not going to go into detail, but the most important, being as a trauma and orthopedic surgeon, this is the responsibility of us to stand and deliver. We can't direct the others to do what is our job to do it. So stand and deliver the ATLS protocol, which stand with airway, breathing, ventilation, circulation, and that's where we have to keep in mind this is a pelvis trauma. That's we have to do something to control their hemorrhage, disability, neurological evolution assessment, exposure. The whole body need to be exposed to see the associated other injuries. Resuscitation, as we all know, aggressive resuscitation and management for these patients are essential for the maximum survival. And this secure airway in the first hour, if we have seen in the slide, 40% is due to some airway problem or their airway might be stuck. So we have to prevent it. And 15 to 20% is due to hypotension. So first, always secure airway. We know how to secure airway, cervical region, breathing, ventilation, and again circulation. And we have to bleeding control. We have to put a 2 whiteboard cannula. So they start with to deal with their shock that they are presented to us. Most of them they present with the hypovolemic shock, so that we're going to talk about it. Again, resuscitation, we have to keep in mind, we might need to put a nasogastric tube. We have to be careful about the fracture the skull of skull base. Whenever we need to put a catheter, because we want to assess about the patient input output to see how it is evolving from the shock scenario. But at the same time, this patient has some genitourinary injuries. We have to keep in mind for when this patient with any blood admitters, perineal ecchymosis, and DRE to see high riding prostate. And we have to continue monitor patient oxygen, pulse, and everything. So these patients, when present to us, they are in shock. So we have to understand these patients, which type of shock it is, and how we have to manage it. So every they are mostly they have that is a hypovolemic shock due to some hemorrhage. So this how we going to classify or categorize a patient when he presented to us, and this we classify according to the blood loss at the time of the presentation. And the parameters that we have is basically pulse rate, blood pressure, pulse pressure, respiratory rate, and urinary output. So as per when we going to start, when the pulse of the patient is normal, or it might be smallly decreased, or his BP I'm just talking about, pulse is till 120. These are the patient which can be compensated with our acute management of resuscitation. If the patient having a pulse more than 140 and blood pressure is undetectable, these are the patients which need to be seriously resuscitated and aggressively need to be addressed, because they are in the state of decompensated shock. And if we not be going to treat that, they again going to end up in the triad of that, in which acidosis, coagulopathy will going to take place. How we resuscitate these patients is we're going to resuscitate with the isotonic solution. And of course, the best replacement is blood with blood. And at the same time, we have to understand, we have to decrease that third body space. We have to take care of the bleeding that might be happening internally. And that's where it should be in kept off our mind. So once we're going to start the resuscitation, we have to see how it is responding. Is it rapidly responding? So these are the patient mean they have the minimum blood loss of 10 to 20%. If there's a transient response to what you address, what you resuscitate, and that's mean these are the patient with moderate blood loss of 20 to 40, and they're likely you need to need some emergency operative intervention. And in spite of every effort, if these patients are not responding, that's when they have a severely hypertensive hypertensive shock, and that's where you have to emergency at the same time plan for operative intervention, at the same time need the blood and further acute management. And then we go to the secondary survey. We know about ample history that we take, and adjuvant to secondary survey, we have some tests that we have to keep in mind, but it always comes after the ATLS protocol. We do fast in the emergency, but negative fast does not rule out abdominal visceral injury. So that's something like you have to keep in mind. Diagnosis of peritoneal aspirate, this is these days, it has been absolute, but it is sometime we need it in the probe in this specimen. The fast is negative, but it's not been done these days. And of course, we all know CT scan, gold standard. Once the patient is stabilized, that the patient can be shifted to the CT scan area, then where we can do the CT scan. But unstable patient, if is there, so we can't shift the patient to CT scan to see what is the damage have been placed. And we can, at the same time, we can have some idea information about is any abdominal injury or about the pelvis itself. So these are the armamentarium that we have got in those patients who is having non-responding to our acute resuscitation. The pelvic angiography embolization. Remember, arterial cause is only 10%. So it doesn't mean every patient need embolization. In spite of all the management which we did, if it will not going to help us to reduce the hemorrhage of the patient or blood loss, that means this patient need pelvis angiography. So periperitoneal packing, this is a very life-saving the surgery, but it takes hardly 10 to 15 minutes, and we're going to talk about it. Emergency laparotomy if there is any visceral severe lifter injury or application of pelvic external fixator will go to decrease the dead space. So this is the algorithm. We all have seen it. We all follow it. Patient presented with suspected ring injury. If it is hemodynamically stable, we know what to do. We go to the complete the secondary survey, and we do the CT scan for the further definitive management. If the patient is unstable, so that's where what we go. We try to temporarily apply a pelvic wrapping, and then we're going to see how the patient is do after resuscitation. And then if we're going to be hemodynamically stable, that means we can go and follow the other step. If the patient respond to fluid but require ongoing transfusion, that means this patient need a CT scan inlet at the same time and might require some emergency. If in spite of every effort, the patient is not responding to resuscitation, his BP is dropping, the pulse is still on the higher side, he is not making urine, though that's where that a patient need to be taken to the theater where you have the other option just to stabilize him. So of course, these patients mostly when presented to us, we have to do a damage control orthopedic, and that's where we have to try to limit or minimize our operation time in this patient, because of, again, there's another concept of a second hit trauma if we're going to go for the definitive therapy. And these DCO, we just temporarily stabilize the pelvis. Resuscitation we have to give, and we put an external fixator, that may be anterior external fixator or C clamp. And the surgery definitive management can be later planned after 5 days when the patient is stabilized. So this is commercial device that been used for applying this pelvic binder for our resident. Just remember, this binder should not be on the abdomen. If you're going to be on the abdomen, that there may be abdominal compartment syndrome can develop. It should be on the greater trochanter, a point of ponder we all have to keep in mind and make sure that is happening. This is another simple way. This is through in the emergency use that you just, with the help of a sheet, the plain sheet, we can just apply this pelvic binder. This is another way. Another cotton sheet, we can apply this pelvic binder easily. That can be done in the emergency by ourselves if the commercial is not available. So this how it is applied in X-ray. If you can see, they show the difference when this pelvic binder was applied. When you're going to apply a pelvic binder, what you are doing, once you are reducing the fracture, you are decreasing the third space, and you at the same time you are giving the pressure tamponade effect for the bleeding to stop. External fixator, for if there is anterior iliac wing fractures, we apply anterior external fixator, and the best is superior acetabulum. We put 2 screw right and left into anterior split screw because of this. This is a good bone, or you can put 2 of the Sean pin at the level of the iliac crest, and you can just fix it together. And C clamp, that is for the posterior pelvic ring injuries. The C clamp is being required. It requires fluoroscopy and technical expertise for the applying if there is a posterior pelvic disruption. This is how it has been applied. At the level of the anterior superior iliac spine, we make line down, and the greater trochanter, we make line. The intersecting point is where we have to apply this C clamp, and that will going to reduce the fracture and posterior ring disruption. So it has its own merits and demerits. So you have to keep in mind. Pelvic packing, this is important. This is also a life-saving condition. Very, if you can say, it's a minimum time consuming, but patient with hemorrhage with abdomen and pelvic, this mortality raise to 40%. So packing is it decrease this causing a tympanic effect for the posterior venous plexus, and that can be done, and it should be for the pre-peritoneal and retroperitoneal stage. We have to put a 5 abdominal sponge, and it can help you to resuscitate the patient. So another thing, for 10 to 15% of the patient who having this hypovolemia because of some arterial bleeding, so we have this option of doing angioembolization. So this is a very important that we all have to understand, okay, when to definitively fix the fracture. In 1 to 4 days, that's where there's a hyperinflation phase, and in second weeks, it is immunosuppression phase. So the time between 5 to 10, this is a window that is where it is safe, where you can do a definitive treatment. Once damage control orthopedic is being done, patient is stabilized, hemodynamic is stabilized. So it's a 5 to 10 day is a time duration once one where the definitive surgery can be done. Remember, this pelvic fracture need to be addressed as a polytrauma patient, and where we need to have a multidisciplinary approach. Blood loss does not correlate with severity of the fracture, and we need to have the different investigation for the to know about the different organ injuries. Be wise, get some specialty involved early. Thank you very much.
Thank you, Dr. Kazim. Mashallah, it was a very enlightening talk and it was a very important topic. Next topic by Dr. Mehrose, but I would request our panelists and our presenters to kindly keep a watch on time. Obviously, 2, 3, 4 minutes doesn't matter. So I request Mehrose to come on and kindly start your presentation. Share and start. Jazakallah.
My screen is being shared now, right?
Yes, we can see. Mehrose, you can start immediately.
All right. Bismillahirrahmanirrahim. I'm Dr. Mehrose Amir, and it's a big honor for me to be here and part of this activity with all the seniors being the faculty. I'm going to discuss the indications of surgical intervention. Much has been discussed about the pelvic anatomy, and obviously the most important part is that there are two components, the ligamentous parts and the bony parts. So keep in mind that the ligamentous parts are the ones that are the most major problems. Bones heal themselves very good, but ligaments don't heal themselves very well if they are not well reduced and well kept together with a proper fixation, or at least protection if you are managing them conservatively. So gradually the threshold for surgical fixation is becoming lower and lower and lower with modern practices and modern researches as per regard to the mechanical stability. Be in mind that as compared to we want to talk about the pelvic ring, the posterior ring is the most important part, which supports 90% of the stability of the pelvic ring. So if you're discussing about the surgical indication, first of all, you have to describe what kind of injury you are dealing with. So in the x-rays, you might want to see the degree of displacement, the stability of the pelvic ring via examination, the direction force that is can be deduced by the history, and the state of soft tissues especially is important, including whether the injuries are open or closed. The anatomic injury of the pelvis and other associated injuries to the patients. So all these factors, when they are combined, so what we get is actually a personality of fracture. What has been defined by pelvis and acetabular fracture expert as a personality of fracture. It's a good fracture or it's a bad fracture. It's a good fracture in a good mood, or it's a good fracture in a bad mood, or it's just a fracture that is altogether bad. So that's what we have to find out and treat it according to its mood. So you have to find out the fracture personality, and then you can decide that can we go for surgery, or should we wait, or what should be done at the moment. Dr. Masood Umar has elaborately discussed Young and Burgess classification. I am going via the tile classification. It's relatively easier when compared, although it includes all the Young and Burgess types as well. So tile A has stable pelvis types, and tile B are rotationally unstable, and tile C are rotationally and vertically. Both types are both directions are unstable. So what actually is happening, if you look at these injuries as we go down the line from tile A to B to C, what is actually happening is the number of injured structures are increasing, and most of them are ligamentous structures, and when they are contributed to the injury, the pelvis is tilted into the domain of instability. So Dr. Kazim has already elaborately covered the unstable, hemodynamically unstable type of the pelvic injuries. So my focus is on the stable type of pelvic injuries. So there are two phases of pelvic injury management. One is the early acute phase, and the second is the definitive phase. And in definitive phase, you have those fractures in which there is a stable hemodynamics, but either a stable pelvic injury or an unstable pelvic injury. And we are going to ponder over these points. So this is a very good algorithm if you want to treat the fracture, find out the surgical indications, and it almost follows the tile classification, tile A, B, and C. So stable pelvic ring, borderline stability, and unstable pelvic ring. So in stable pelvis ring, if there are not very well displaced, or they're like avulsion fractures or stable compression fractures, LC1, which are being classified, they are stable, they can be managed conservatively. But be in mind, you have to keep in mind that you have to have a low threshold. As per new and newer studies are being done, you have to have a lower threshold for surgical fixation. What really happens is you have to consider again, okay, is it a stable fracture? So what should I do? Okay, mobilize the patient. Or I'm mobilizing the patient. Is the pain increasing? Yes, if it is increasing, get a post-mobilization film. See if the fracture configuration has changed or not. If it has changed, then you might consider fixation. If the patient is elderly and the fracture variety is stable, but it is too much painful for the patient to mobilize without additional fixation, then we can consider fixation. Or if the functional demand is the patient is very high, then we might consider fixation, even stable pelvic type injuries. Borderline stability, again, you have to do, this is the domain in which you have to work out all the fracture pattern and personalities, and then decide what kind of fixation should be done. You have to do examination under anesthesia, might need to do stress films, might need to do C-arm fluoroscopy shots, stress shots, and see what kind of pelvis do you have. And then you can decide whether to fix it or not. And obviously, unstable pelvic ring, there are no doubts about it. You have to do it whenever they're out of the acute phase. You have to do fixation and stabilization for these kind of injuries. So taking apart from just to describe a few points, in lateral compression types, the indication for fixation could be inability to rotate limb past neutral, a complete 100% displacement of the rami, LLD, unacceptable cosmetic appearance like in locked pelvis or symphysis or rami overlaps, or if there is continued pain and special injuries like tilt fracture and lock symphysis. In APC type, if there is a very wide gap, if there is type C, which is obviously you have to fix, if there is a laparotomy being performed, or if there are pubic rami fractures are very markedly distracted, and if there's any other symphysis dislocation or any other injuries like femoral arterial or open injuries that you have to address, then you can go and provide surgical stabilization depending on the condition of the patient. To share a few cases, only a couple of cases, I'll be very brief. So if you see this X-ray, and if I hope the quality is good, but I'll try that. If you can see that there is an avulsion fracture, okay, right. So consider if this patient is a 70-year-old lady. For example, if this is not definitely a 70-year-old lady, but this, if it is a 70-year-old lady, she's a 70-year-old lady, best would be give her a cane, mobilize her, and give her painkillers, and that might be it for her. Maybe that will be the best treatment option. But if she is a 17, he is a 70-year-old athlete, then you might to have fixed these avulsion in order to provide the best function out there. This is one of the old cases that I did, anterior posterior injuries, symphysial disruption along with right side sacroiliac joint disruption. And if you see close on the CT scan, the only anterior ring has been opened. Anterior sacroiliac ligaments are open, not the posterior one. The hinge is intact. So if nowadays, that's the best option to is go for surgical fixation. Whereas in the past, all people would have done is a pelvic wrap or a binder. But that is only for now acute phase, and the definitive fixation, definitive management rests on surgical fixation. So to summarize, the assessment of management of patients with pelvic ring. To summarize, the assessment of management of pelvic ring injury should follow a logical progression. Once a patient with pelvic injury is stabilized, a history and thorough physical examination will provide valuable data. And after all radiological assessments, it is important again to consider the fracture personality, patient circumstances, and functional expectations. Thank you very much.
Thank you, Meroz. Jazakallah. And I will request Dr. Hanif to kindly share his screen and start the presentation without wasting time. And the questions you can send in the question and answer session. And the one who has presented the presentation can answer in that. You can also chat in the chat session so that if we are not doing question answering directly, we can answer them by typing and in other ways. Bismillah, Dr. Hanif, kindly start.
Assalamu alaikum. Bismillahir Rahmanir Rahim. Thank you very much. I'm Dr. Hanif from Islamabad. I'm working as consultant orthopedic surgeon in Islamabad Medical and Dental College. How is voice quality? Is okay? Nasir?
Yeah, it's okay. Yeah, just you have to be little bit loud.
Okay, thank you. My task is to go through the complication and sequelae of pelvic ring injuries. And this is my first slide. If you can see, I just put down the anatomy. If you have trouble here down there on the vessels, you can have intraoperative problem as already elaborated by the earlier speakers. And if you have problem down there, you can have early and late complication of neurological issues, and you can have problem with the organs. You can have problem with the male or female genitalias, and you can have problem with the lower limb. So there are, if we divide the complication, it can be intraoperative complication, immediate post-operative, late complication, and there can be what we have been facing continuously, the sequelae of neglected fractures and sequelae of mal-reduced and mal-fixed fractures. So intraoperative complication, the DVT is topmost. Then we can have visceral and neurovascular damage. Hemorrhage can be life-threatening, which is already described by Dr. Kazem. And immediate post-operative complication or late complication, we can have a long list of disabilities like urinary incontinence, sexual dysfunction, dyspareunia, erectile dysfunction, defecation issues, chronic constipation, pregnancy-related issues, lower limb dysfunctions, postural, sitting, lying, and gait issues. And the same goes with if we have this neglected fractures, or if we have mal-reduced and mal-fixed fracture, we always face those kind of injuries here and elsewhere. So for the DVT, we should give the prophylaxis, and it should be started 12 to 24 hours after the trauma. And Claxane is the good choice. It's short-acting, and we don't need any monitoring. And for those patients where anticoagulation therapy cannot be given, there is the indication of inferior vena cava filters that should be considered. So the other option to deal with DVT is compression stocking. Then we have intermittent pneumatic compression devices or continuous passive machine. We don't have readily available these kind of devices here in Pakistan. To improvise those things, I have just you can say I asked the attendants to do the manual massage of legs and thighs, both legs, both thighs, and there are a lot of attendants we have, so they do it, and then they do the ankle pump exercises. This is very helpful. So home anticoagulation that can be offered only to the selective patient who have high risk of DVT or early history of DVT. So intraoperative hemorrhage, I have taken this statement from the Rockwood, that despite the experience of the surgeon, surgery of the pelvic ring fracture reduction and fixation can be associated with large blood losses, hypotension, and prolonged operative time. That is nicely elaborated by Dr. Kazem. So intraoperative hemorrhage, if we are fixing the posterior ring, we can have superior gluteal iatrogenic injuries. We can have common iliac injuries while doing, iliosacral screws. So if we can control intraoperative, if the patient is stable, there are no issues, we can continue with the surgery. But if we see that the patient blood pressure is going down and there is problem, and so we can stop the surgery. We involve the angiography team and do the embolization. And we don't have that facility, we can't do that. We should have, vascular surgeon along with us and fix this problem first, then revisit again when the patient is stable. So the hemorrhage can be venous, as already said, that it is mostly venous, and there is a tendency of orthopedic or trauma or even pelvic surgeon to focus on difficult reduction, because the pelvic trauma is a highly difficult, field. So they focus on difficult reductions and they ignore the physiology, and it should not be done. There should be close communication with anesthetist, and if there is something wrong, that should be fixed first. Pack, close, send the patient to the ICU. Once the patient is stable, go again, revisit, and do next time. So continue working on deteriorating condition, and accepting suboptimal reduction fixation is not advisable and it is not acceptable. So difficult reduction, this is a challenge, especially in the neglected cases and especially in the maltreated cases. I have few series of such cases. Dr. Umar Nadeem also has been showing us his series of difficult reduction cases. So at times, you have to do one or two, or you combine all of these, maneuvers which are mentioned here to achieve achieve the reduction. So you can use the femoral distractor. It is available in Pakistan. You do the push and pull technique. This is push. This is pull and push technique. And then you can use, Farabaugh clamp to reduce posterior ring. Then you can apply, traction. All of these, combination of these techniques to achieve the reduction in the difficult cases. So this is one of my difficult and complex case I have already discussed with senior faculty. So she's a 25 years old female, had run over injury by a truck. When she presented to me, it was already 1 year and 8 months old. She was maybe not properly fixed. I don't know what was the reason. Anyway, so there was a single screw and X-fix anterior. When they taken off the screw, she had continuous pain, disability. She was not able to walk. She was not able to sit. She was not able to even lie down. So there was continuous problem. So we did this kind of fixation. It took us around 13 hours to accomplish this kind of difficult task. So this is 3-in-1 stage fixation. First, we release the anterior, all pseudoarthrosis, then we turn around, then we release from posterior. We reduce the posterior ring, then we fix with the iliosacral screw, then we apply the lumbar fixation, and then we turn around the patient again and did the anterior plating. There were a lot of questions by senior faculty about this left side of rami, but I could not do it. But the patient now says that she is better 90% than before the surgery. She is doing well. She can walk normally. She can lie down. The pain is subsided, and she is better now. So this is another difficult scenario and very anxiety-provoking scenario is inability to achieve adequate fixation. It can be in the situations like osteoporosis and comminution. And for that, we can manage by 2 iliosacral screw in S1 and 1 in S2. And then it can be augmented with the lumbopelvic fixation. And this is very stable construct, triangular construct in 2 planes. This is very stable fixation. So we can use the transiliac bars or transiliac plate, whatever we like, whatever is can do. So in anterior, the anterior pelvis, anterior ring should also be fixed. So we can do retrograde anterior fixation with the screws. This is one of my case, retrograde anterior fixation of the anterior column, posterior column. Then we did the infix, and all anterior posterior, it's stable now. So LCPs, locking compression plates, they are friends and they are allowed by the trauma surgeons. They are very helpful. But in setting of pelvic surgery, We can use them anteriorly, a bit posteriorly, but we cannot use them everywhere. In-fix, ex-fix is another option. So post-operative wound infection and dehiscence, this is a problem if we have long surgeries, if we have, there are so many factors. So it should be dealt quickly to avoid deep pelvic abscess formation, prolonged more than 3 to 5 days wound drainage and erythema, fever, and elevated WBC in the early post-operative period, first 2 to 3 weeks, should be immediately debrided, irrigation to prevent the osteomyelitis and deep infections. So only percutaneous drainage and antibiotics are not helpful. They are not effective at all. We have to debride thoroughly and take the deep cultures and do the IV antibiotics as per culture for at least 6 weeks. At times we need to put in the antibiotics beads, and we have to consult, the ID consultant, infectious disease consultant to guide us about the antibiotic use. And there we have to go in again and again multiple times unless we get the result. So TLC, ESR, CRP may not rule out the infection, but they are effective tool to measure the treatment response. Contrast CT to see the deep infection, and if the fracture is united, we can remove the hardware. One of my experience that I removed the hardware, one of my infected cases, once I removed and debrided, the patient is clean now. There is no further discharge. So newly recognized post-operative neurological deficit. It's really, a disheartening situation, very depressive situation. So to avoid that, we have to have careful pre-op examination and don't always do DNV intact, distal nerve intact. No, individual neurological examination of all lumbar sacral plexus. This is, very difficult. If possible, it's difficult. If this is not possible, then we can write only what we can perform. What is known? What is known we can write down. So what is unknown, we cannot say generalized and that everything is intact, because in post-operative period, if we have some neurological deficit or issues, then it's not good. So newly recognized post-operative neurological deficit. If new onset post-operative deficit, the investigation of choice is not MR, it is CT, because MR have a lot of artifacts and doesn't give us clear picture. What all we want to see that our metal, whether it is inside the foramina or it is outside in a safe zone. So to see that, we have to do the CT scan. And there are 4 scenarios commonly. Misplaced screws, as seen in this above picture. Then overcompressed foramina, as we can see here down in the blue circle. And there can be intraforaminal fragments, and there can be intraoperative manipulation, a problem that is reversible. That is we have not to bother about that. So if we have scenario like 1 to 3, and there is no motor sensory loss, that can be treated conservatively. But if there is motor sensory loss, we have to revisit and refix and do the adjustment. To avoid this kind of overcompression, always use fully threaded screw. I don't know whether the Karachi people have it, but still in the Pindi, I keep asking my vendor. He has not supplied it, but I'm conscious and cautious to fix the sacral injuries. I use only 32 mm, but anyway. So the outcome of delayed or malfixing, this is the problem. This is the challenge. This is the challenge because the damage is already done. So the pelvis is a spongy bone, and to reduce again, we can do a lot of hard work, as well as it's complex and it carries a lot of complication. So it is difficult to achieve the reduction. Lengthy, exhaustive procedure, as we took 13 hours to accomplish. Increased rate of complication, functional outcome is guarded. There can be chronic pain afterwards, pelvic obliquity, gait abnormality, sitting, lying issues, childbearing issues, constipation, and that is the issue. Sexual issues, as we already discussed, erectile dysfunction and dyspareunia. So another complication is hardware failure. The same old trauma principle goes that union before implant. If we have stable fixation, if we have adequate reduction and stable fixation, we don't have this problem. But if we have, like in this, this was vertical shear, and the patient was fixed with 2 screws, good adequate fix. I don't know what goes wrong, but he came to us. He came after 2 weeks of this, the failure of the implants, failure of the fixation. So in this case, the second one, this is again vertical shear. This is maybe dentistry. So vertical shear, but they fixed with 2 good screws, but they did not do any fixation anterior. As it is said that 40% of the body weight is through anterior ring. So when we are fixing the posterior, we have to skewer the anterior ring as well to avoid this kind of complications. So my conclusion is that good planning should be done. There should be teamwork. You have to discuss your plan with all the OT staff, not only doctors, not only assistant, but your OT staff, your radiographer, everybody. Discuss the plan with the team, make notes and put on the wall. What is your going? What is your stage 1? What is your stage 2? What is your stage 3? What you are going to do if there is something wrong? So when you are going to invite, when you are going to call in your vascular surgeon, everything should be mentioned. And the vascular surgeon and these people, they should stand by. Imaging, before giving the incision, you do imaging yourself. Do all the inlet, outlet, the special views, all the views should be done by the operating surgeon. And before all the pen drapes. And there is a good technique to mark the wheels of the image by the tape, fix on the floor. You have to do some seat changes. And you have to have the pelvic table and vascular surgery and radio angio backup, ICU backup. It's not an easy job, I would say. Must be learned first. I've seen a lot of complex cases and what neglected, or you can say malmanaged cases. For that, I make this kind of thing that public awareness is very important to tell the people that these injuries are manageable. They can be they have good results in good hands, and not everybody should treat them. Everybody has right to learn. Everybody has right to fix, but not everybody should fix them if they don't know how to fix them. No to maltreatment, no to neglect and delays. 5 to 14 days is ideal time to fixation. And you should have comfortable helping environment, no rush, good sleep at night before the surgery. Thank you.
Thank you, Dr. Hanif. Dr. Intikhab would be at the airport. Sir, can you hear us, Dr. Intikhab, sir? Saad, can you upload the cases for Dr. Intikhab?
Yes, I can. I request you to brief this portion.
I will do that. Okay, this is the question answer session. There will be 2 cases from pelvic injuries, and there will be a small scenario that will be followed by a few questions. We will go quickly through the questions, and if any discussion is needed, then we can actually answer that. Otherwise, it is self-explanatory. So once you will complete the stem, there will be a poll which you will click and submit the poll. And after a few seconds, we will announce and show the results on the screen. So we will go with the first scenario. Dr. Intikhab, should I continue? I think Dr. Intikhab was in the airport and there might be some announcement there. Anyway, so we will start with that. Bismillahirrahmanirrahim. 25 years old male had a road traffic accident, car rollover injury. The initial recordings in accident emergency was blood pressure hypotensive and the pulse was 130. He sustained fracture with rectum exteriorized. Abdominal bruising was there, but CT abdomen has no positive finding and the solid viscera were normal. So next slide, please. These are the pelvic x-rays. Kindly have a look at that. Next slide, please. So the x-rays are in front of you. So what would you start your management with? What would be the first step in accident and emergency to manage this patient? Start the poll, please. Please answer. The panelist and the attendees both can answer this.
I request other to please vote.
All the attendants and panelists all can vote. Once we will have voting more than 50%, we will show the results.
Last call for the participants to please poll their vote.
How many person has responded?
Out of 48, we have received 24 now. That the 52% response we have received. So I'm going to close this session of polling. So the results are like this.
Okay.
I hope you have seen this.
Yes, you can see that. Thank you very much. So the majority of the participants, they agree that obviously in accident and emergency, we will manage the shock first, as Dr. Kazim has rightly taught us. Okay, we'll move to the next question.
Yes.
Next, please. Okay, so Saad, kindly go to, okay. So now we will classify the fracture. This is Stiles classification, B1, B3, C1, C2, and C3. So kindly classify that. Show the poll, please.
So the last call, those who did not poll their vote, please vote. Thank you.
Okay, show the results.
Yes.
Okay, so there has been a variety of answers there, probably because I think we discussed Young and Burgess, and now we are asking Tiles question. Anyway, this is a vertically unstable fracture as well, because this is unilateral. So the wound goes for C1. So that's not an issue. The idea is not of telling someone right or wrong. It's just an exercise, and I do understand that obviously on a single shoot X-ray which is not complete, one cannot actually classify completely. Anyways, we'll go to the next question. So considering the whole scenario, which we have discussed, that the rectum is exteriorized, so the patient is now stable and is admitted. So what procedure would you like to do in the next 24 to 48 hours? The options are there. Okay.
Last call for those who did not poll. Okay, now I'm ending this.
All right. So majority, obviously, they agree that diversion colostomy is the right thing to do, and that is the right thing to be done. Obviously, in this case scenario, internal fixation is not the right choice to do. Okay. Next, please. So considering the whole scenario, which orthopedic procedure would like to do? Either anterior plating, and once the patient is stabilized, diversion colostomy has been done. Now to stabilize the pelvis, what should be the best option in your opinion? The options are there. So
Okay, now I'm going to add.
okay. Now there has been a tie between anterior plating and posterior transiliac bars, anterior external fixation, percutaneous iliopsoas screws. You see, all these options are right, and everybody with his experience and in expert hands can do what he likes. So So what we did was fixator interni and percutaneous iliocycle screws. This is the next slide. Obviously, I did not, because the divergent colostomy was there, so we were afraid that if you put something inside, that might not get infected. And the external fixator were also not placed because the pins will be exterior, and they, sometimes then one cleans the colostomy, then the contamination can occur on the pin sides. So that's why we opted for this option. Okay, we'll move on to the next scenario. So the second scenario is a 40 years old male who fell from of a high speed motorbike, complains of pain in the lower limbs and lower abdomen. The patient is vitally stable. The rest of the examination is unremarkable. So next please. These are the X-ray in the accident and emergency department. Okay, next slide, please. So the most probable injury the patient sustained would be fracture sacrum or head of femur, or fracture left acetabulum, or fracture dislocation of right SI joint, or disruption of the left SI joint. So the pole, kindly show the pole. Okay, I think everybody have answered. Kindly show the final answer if sufficient answer has been received. Right. So very rightly recognized. So the patient is having right fracture dislocation of the right SI joint, very visible on the X-ray. Next, please. Question. So how would you confirm the injury further? So what modality are we going to use? So show the pole. Okay.
So receive the sufficient amount of pole.
Okay. Okay, you can end the poll now.
So this is the result.
Right. So that is very rightly said. CT scan and 3D CT scan. Obviously, the actual thing is CT scan, and then 3D CT scan is a software which actually converts, which collages the images and converts the CT scan images into a 3D constructed model, which is then printed or can be seen on the X-ray. But the right modality obviously is CT scan. And in these kind of injuries, the axial CT scan is of the most importance. Next, please. So these are the axial images of CT scan. Kindly have a look and find out what are the different injuries you can identify. Okay, next slide, please. So the CT scan is again in front of you, and looking at the CT, which option is the most right? Patient is having fracture left L5 vertebrae. Patient is having crescent fracture, ruptured bladder, or you can see some injury which warrant taking the patient directly to theater, or patient is having right crescent fracture and left L5 fracture. Start the poll, please, Saad. Okay. If you have received sufficient answers, can we end
Not
the poll?
yet. Yes, I will. Last call for those who did not poll yet. Please poll it. Okay, so I'm going to end this poll. So the result is
Right. So very rightly identified. Obviously, the patient is having right recent fracture and left L5 fracture. Very right. Okay. Next question, please. So how the crescent fractures are treated? Conservatively, by pelvic binder, by external fixator, by C-clamp, or none of the above option is true. So what stem would you choose? Start the poll, please. Which one is the right answer? Okay. Yes, sir. You can. Okay, that is right. So obviously, crescent fractures are intra-articular fractures, and we have to treat them with internal fixation. It can be an iliacyclo screw, or it can be a plate which is applied externally, or a screw into the iliac wing. So whatever option you choose, but obviously none of this is the right answer. Okay, so I
I
think
think
this is
that's
the end of
the
the
last session.
Yes, so we will move on to the acetabular session, a session of the acetabulum fractures. In that, the first talk is by Professor Raja Irfan Khadir Saab. I will request him to kindly start share his screen. So, there's a chat box as well, and there is a discussion going on in the chat box. So the attendees and panelists kindly give your opinion in that, so that side by side we can also have discussions on the chat box.
Thank you. Thank you very much for inviting me to participate in this webinar. Can you see my screen?
Yes, sir. Very rightly, sir. Your voice is clear. A little bit louder. The voice is perfect.
So, topic given to me today is radiological assessment of acetabular fractures. It would have been very nice if somebody had given a talk on the classification of acetabular fracture. Would have been easier for the participants, the young orthopedic surgeon, to understand the radiological assessment and how to read the X-rays. Anyhow, I will go through these the radiological assessment of acetabular fracture, which will also actually encompass some of the classification aspects as well. So as you all know that acetabulum is an incomplete hemispherical socket with an inverted horseshoe-shaped articular surface. Can you see my pointer? Could you see the pointer?
Yes, sir. Yes, sir, we do.
Thank you. So this is the incomplete hemispherical socket, and it is supported by two columns. The articular surface is composed of and supported by two columns of bones, forming an inverted Y. As you all know, the acetabulum is actually composed of two structures, anterior column and posterior column. A few lines which are very important radiologically. I'll show you on the X-rays as well in a minute, but here it is a model of the pelvic bone. This line is called iliopectineal line, which starts from the ilium, goes over to pectineum and up to the symphysis pubis over the pubic tubercle. The other line is ilioischial line, which starts from the ilium and goes to the ischium. Then you can have you can see two more lines. One is the posterior margin and other is the anterior margin of the acetabulum. You can call it anterior wall and posterior walls. Again, the same line. This is the iliopectineal line, And this is actually the anterior limit of the anterior column. It is the limit of the anterior column. The green one is ilioischial line, and which is a limit of the posterior column. This is the anterior lip, and this one is the posterior lip of the acetabulum. This blue semicircle depicts the superior weight-bearing surface, terminating medially into the teardrop. I'll come to this teardrop in a minute again. If you look at the X-rays again, this is the ilioinguinal line, this is the ilioischial, teardrop, dome, anterior and posterior walls of the acetabulum. Now these are the Jude views. This is AP view. These two are the Jude views. This one is oblique, iliac oblique, and this is the obturator oblique of the right acetabulum. Here, one can see the anterior wall of the acetabulum. This is anterior column outline. This is the posterior column outline. And this one, this line on the X-rays shows posterior wall of the acetabulum. Again, anterior wall, posterior wall, anterior wall, and posterior wall. I think this is a repetition again. Now, just a few words about teardrop. The internal limb is actually the outer wall of the obturator canal. And the external limb, this one, this is external, this is internal. The external limb is made of middle 1/3 of the cotyloid fossa. And the inferior border actually is the margin of the ischiopubic notch. Now, CT scans are very crucial and very important part of radiological assessment of the acetabulum fracture. In transverse sections, I will just give you an example of that, and then we'll go into detail as well. It shows the fracture lines, extent and location of fractures, orientation of fracture lines, whether it is the posterior wall, anterior column, transverse fracture, this one, or maybe a T fracture. It can show the rotation of the fragments, how much they are displaced or rotated. It will show the status of the pelvic ring, if there is any other pelvic injury associated with the acetabular fracture. It will show you any intra-articular free fragments, and if there is any impaction of the margins of the acetabulum. A few signs which are quite pathognomonic of some injuries of the acetabulum. One is gull wing sign. It describes the appearance of a posterior fracture dislocation of the hip. Posterior fracture dislocation. If you see this gull wing sign, it depicts fracture dislocation of the hip posteriorly. The posterior displaced fragment of the acetabulum combines with the rest of the acetabulum to create a double curved shadow which resembles the silhouette of flying seagull. Now, CT scans are very informative, but if they are taken in at least 3 mm interval axial cuts, it should include whole of the pelvis, because there might be associated injuries with the fracture acetabulum in the pelvis, and it should be compared with the other side as well. Again, on obturator Jude views of this fracture shows a spur of the bone just superior to the acetabulum dome. And this is pathognomonic of the both column fractures. This CT scan shows a posterior wall fracture and impaction of the bone here as well. And this is very important to note because open reduction would be only possible perfectly if it is raised to its original anatomical position and the defect is filled with the bone graft. Here in this CT scan, one can very clearly see the intra-articular fragment of the bone, which needs to be removed before a congruency of the hip joint is achieved. This is an AP of the pelvis, and it shows posterior dislocation of the hip joint with the posterior wall fracture, which is quite evident here. The same in an oblique view, hip dislocation with posterior wall comminuted fracture. You can see there are at least two pieces of the posterior wall of the acetabulum. And if you take a CT scan, this is the fracture of the posterior wall. One can see the comminution and an intra-articular and trapped fragment of the bone. Now this AP view of the pelvis shows a disruption in the posterior column here. And if we take and here one can see the hip joint is actually not congruent as compared to the other hip. And if you take obturator and iliac views, one can very clearly see this fracture, which was not visible on AP views. Can you hear me, please?
Yes, sir, we can hear you.
Thank you. So here on an iliac oblique view, in Jude series of X-rays, one can clearly see the disruption of the posterior column and sublux dislocation of the hip joint as well. These are the transverse cuts of their same injury, and one can see the posterior column is fractured here. The head of the femur is subluxated posteriorly along with this posterior column. Same again, the hip joint is dislocated posteriorly with a big fragment of the posterior wall and the posterior column fracture. This is the 3D CT showing the posterior fracture of the posterior column and some comminution as well here. This was fixed with a posterior plate, AP view, and the obturator view, and one can see the hip joint is reduced nicely, and the fracture as well. This is another posterior column with posterior wall fracture. One can see the disruption in the ilioischial line. This is the disruption here. This fragment should have been here, and the line has been disrupted. The ilioischial line has been disrupted, so it shows a posterior column fracture. Here one can see a posterior wall fracture as well, but this is not evident on those X-rays. This one shows very clearly the posterior column fracture and accompanied with the posterior wall fracture. Here, posterior column fracture and fracture of the posterior wall of the acetabulum. Here, posterior column fracture and posterior wall fracture accompanied with it. And this was fixed with a plate and a separate screw to fix the posterior wall fragment. This screw has been used for posterior wall fragment fixation and the plate for posterior column fixation. I won't go into the classification, but now coming to the anterior column fractures, one can see there is a clear disruption of the iliopectineal line. Here, the excuse me, the head of the femur has protruded into the pelvis because of lack of support. The dome is empty here. These are the iliac and obturator views. In the iliac view, you can see the posterior column is intact, but in the the obturator view, you can see clear disruption of the anterior column from here to here, and the gap is occupied by the femoral head. This is a CT scan of the same patient. You can see the posterior wall fracture and the posterior column fracture. This is the wall, this is the column. And this has been fixed, I beg your pardon, anterior, not the posterior, the anterior column and the anterior wall. And this has been fixed with an anterior plate, reducing the fracture and giving it perfect stability. These are the iliac and obturator views, and one can see the fracture has been perfectly reduced and fixed with this anterior plate. Transverse fractures is like, if you should see it diagrammatically, it will show like this. On the X-ray, one can see the transverse fracture like this. I apologize for the poor quality of the X-rays, but one can see on the obturator view that it is a transverse fracture. Here one can see it's coming from anterior to the posterior. Again here. And this is again anterior column plus posterior hemitransverse fracture. That was a transverse fracture. And this is a anterior column, posterior hemitransverse fracture. Hemitransverse is an incomplete transverse fracture. Now this one shows anterior column fracture here and posterior hemitransverse fracture. I'll show you on the CT scan. This is the fracture of the anterior column here. Fracture of the anterior column. And posterior hemitransverse. One can see this line. It's not completely going to the edge of the bone. So this is anterior column plus posterior hemitransverse fracture. And this has been fixed with again. To fix the anterior column, the anterior plate has been used. One can see the fracture has been reduced perfectly and fixed with the plate. Then comes the T-type fracture. One can see the configuration of the T-type fracture in this picture. I'll show you how does it look like on the X-rays. X-rays are sometimes not very informative. For that, you have to do the oblique views. This is the obturator oblique view. One can see the fracture here, but not very clearly. It will show on the CT scan very nicely, especially on 3D images. You can see a fracture going from anterior to posterior, and one limb of that Y is going inferiorly and maybe exiting through the inferior ramus. So this is a T-type fracture. And this one has been fixed with, a screw going through the anterior column and a plate from behind. Both column fractures will look like this one. One can see the disruption of the iliopectineal line and also the ilioischial line. The ilioischial line is broken, so it shows that it is a fracture of the posterior column, and also the iliopectineal line is disrupted. So this is a typical both column fractures. This is a 3D image, 3D scan, and you can see the anterior column fracture. And from behind, if you look, there is a posterior column fracture with fracture line extending into the iliac blade. Again, from posterior, this is the posterior column, and from anterior, if you look from the anterior aspect, this is the anterior column fracture. And this has been fixed from both behind and from front. The anterior column has been fixed from front and the posterior from behind. Here you can see the anterior column being fixed, and here the posterior column. This is a broken drill bit inside the head of the femur, did not cause any problems, and he had a full functional recovery. Thank you very much. If there are any questions, you are most welcome.
Thank you very much, sir. Jazakallah. Dr. Wazir, you can start your presentation now. Saad, you have to upload Dr. Wazir's presentation, and he will be doing the indication of fixation.
Thank you very much, sir, for giving me this opportunity. Can you hear me, sir?
Yes, we can hear you. Saad will start your presentation.
Okay, sir.
Yeah.
I am Dr. Wazir Ahmed, Assistant Professor, Orthopaedic Surgery, Bolan Medical College, Quetta.
Saad, are you uploading the presentation?
Yes, sir, I'm doing that. I need a minute to upload.
From now on, the other presentation are still, we are left with, including Dr. Wazir, we still have 3 presentation and 2 question answer, and maybe in the interest of time, in my presentation, I volunteer to skip few of my slides, and I hope that my colleagues also would try to manage the time, inshallah, and maybe we might skip the...
Sir, can I request you to please upload Dr. Wazir's? I'm unable to make a screen share now. Presentation is with you also. So can you please share his screen?
We can ask Dr. Faiz to do his
Sure.
do both presentation, and then by meanwhile you can actually sort out what the problem is, and Dr. Wazir will
Fine.
after. Dr. Faiz, are you
Fine.
here?
Yes, I'm sharing my screen, Saad.
Jazakallah. Bismillahirrahmanirrahim. Bismillah kare.
Bismillahirrahmanirrahim. The topic given to me is interior wall and interior column fractures and classification and their approaches. Because of time constraint, I will go through quickly. So what's the interior wall fracture, the classification? So interior wall fracture is usually manifest as disruption in the iliopectineal line. And this is best seen in iliac oblique view. However, CT demonstrates fracture in sagittal plane of axial cut. This interior wall fracture, it has a typical trapezoidal shape, and it starts proximally below the level of the interior iliac spine. The location of distal fracture line is variable at superior pubic rhombus and can be incomplete. So this is an X-ray And this is the double break sign. It's called the double break sign in the interior column of the ilio break in the ilio pectineal line, and this is the iliac oblique view. You can see the fractures. So these fractures look like on these two views as such. This again, this dotted line indicates the intact posterior column. The interior column is break, and it is here that it's look like a trapezoidal shape. So it's a diagrammatic representation how the femur head behaves. As you can see, its subluxar dislocate interiorly, and you can see also the fracture of the quadrilateral fragment. And this is very important, as Professor Raja Irfan Kader Saab has explained the marginal impaction. So it's one of the pathology seen in these interior column fractures, and it can be seen on the, as you can see on the radiograph as a red line. And the importance is you have to treat this, as Professor Irfan Saab has rightly said, that you have to openly reduce it, elevate it, and then treat it, marginal impaction. So interior wall fractures, as you know, Letournel is the father or a pioneer of this fracture. He has a large series. So according to him, it contained also a portion of the interior column, interior to the acetabulum, that is extension to the quadrilateral surface, but it is different from interior column fractures. And the difference being, it leaves a large portion of interior column connected to the ischial buttress. And this same definition, more or less, it is adopted by OTR AO classification. However, Harris and Koo will describe this classification a bit in further slides. But it says Harris is just a chip of the interior lip of the acetabulum, this interior wall fracture. And this is what Harris says. According, as you can see, this star shape, it just indicates that it is interior wall fracture. They're just a small piece of the interior column of. So this Harris classification is a little bit different from the other two, that is Letournel and Hoy. Interior column wall fractures do not involve the obturator foramen, whereas the interior column fractures do. So that's a difference between the two. True interior wall fractures will involve a segment of the inner table of the pelvis, that is acetabulum brim, whereas a high superior ramus fractures will not involve the pelvic brim and will not involve the significant segment of the articular surface. So that's the main difference between these two fractures. Interior column fractures, they typically starts at the inferior pubic ramus, extended cranially up to the iliac fossa, often reaching the iliac crest at variable levels. This interior column fractures, including interior portion of the acetabulum, which is disconnected from the sciatic buttress. The fracture crosses the obturator foramen, a feature that differentiated from an interior wall fracture. So that's the main difference between the two. However, now these differences, they are very well explained by the introduction of the CT and 3D images. If you took an axial CT, the dominant fracture line at the level of the acetabulum roof is in the coronal plane. So it's the diagrammatic representation of these fractures. As you can see, this is in one view, and this is another. This star indicates, and this the fracture line extends up to the ilium, and most cases it goes into the iliac wing as well. So this what we have said in the earlier, if you took just above the acetabulum a view, so the fracture will look like this on CT scan. So again, how it behaved, the head behave in these fractures. So this is a diagrammatic representation. There is a fracture of quadrilateral space, quadrilateral fragment, and the head is usually it is subluxed interiorly and medially in these fractures. Again, marginal impaction can be seen with these fractures, and this as it is shown in this red lines and green lines. Now, how these fractures, interior column fractures, they are classified. So they are broadly classified into 4 types based upon the fracture extension. Very low As you can see, the fracture just sets the iliopubic eminence, and the fracture when the proximal extension, when it reaches up to sulcus, it's a low. Intermediate, it involves the ilium bone, but not up to the iliac crest. And high grade, it involves the iliac crest. Sorry. Right. This is again the radiographic appearance of these 4 fractures. Very low fracture, as you can see, it's just a fracture at the iliopubic eminence, and these are the iliocoblique and retrooblique. This is a low fracture seen on these X-rays. This is an intermediate pattern, and in the higher pattern, as you can see, the fracture, it extends up to the iliac crest. Now, what's the frequency or incidence of these interior wall and column fractures? So we have, as you can see, Letournel, it is he has a largest series of 567 patients, Mata 255, and Dakan 85. So as you can see, the interior wall fracture, they are the least common, 1.6, 1.2. And similarly, the interior column, they are also the least, just the second least common, the posterior column after. So these are least frequent fractures. But the question is that why we study these fractures? What's the importance? So it's here that interior wall acetabulum, the least satisfactory results among the simple fractures. That has been said by Letournel, and he's attributed these results to these, that these are usually in elderly osteoporotic bones, osteopenic bones. These fractures are difficult to reduce, prone to reduce, lose reductions, and since they involve the roof, joint failure is more probable. And these are some of the results. Even Letournel, he was able to just 65 good and excellent result. Genudis 676 good and excellent. Husman 73, 85% good results. So that's the importance that you have to reduce these fractures and keep an eye on them. They lose reductions. They are in osteoporotic bones. So that's why we have to study these fractures. Now, what is the classification? So broadly, these are the 3 classifications they are used to classify these fractures: Letournel and Jody, AO and OTA, and Harris and Koo. So this is the famous one. As you can see, the 5 elementary fractures, the 5 elementary and the 5 associated. So it's the interior wall fracture, as you can see here, the first one, and the interior column fracture is the third one. Now this classification is the AO or OTA. As you can see, the number is 6-3. Actually, originally it was an AO, then in 1988 with OTA they've modified a little bit. So the number is 6-3, and as you can see, the interior wall fractures, sorry, over here, 3.1, it's interior wall fracture, 3.2 interior column fracture. They have been further divided into 3.1.1 interior column high and low fractures. Harris and Koo, it's a CT based classification, and category 0 isolated wall fracture. So interior wall fractures lies in this. Category 1 is isolated column, so interior column fracture in this. So Harris, it's not commonly used, but it's a CT scan to best classification to classify. Now coming to the approaches, which surgical approach should be used to assess, to treat these fractures, interior wall and column? So these are the 5 factors. As these are the interior fractures, interior column, so the approach must be interior, but these factors must be 5 factors. It's in fact for every acetabulum fracture, you have to take into consideration the fracture pattern. Like it's interior fracture, obviously the approach must be interior. Or if it's associated fracture with interior, you can have extensile approach. Condition of soft tissues, presence of associated major systemic injuries, age and projected functional status of the patient, and delay from injury to surgery. So these are the 5 factors that determine your surgical approach. But the commonest approach for these interior column and wall fracture is the ilioinguinal. iliofemoral, modified stupa, and pararectus approach. So I'm used to ilioinguinal, and it's the classical approach. And my advice, rather, literature said that every orthopedic surgeon who's practicing pelvis acetabulum must master ilioinguinal approach. Then he can have the other approaches. Now, what the literature said about these approaches, as you can see, the from in 1965, it's a overview of the articles published on these approaches from 1965 to 2018. As you can see, the green one is the ilioinguinal, the blue one is modified stupa, and the yellow one is the pararectus. As you can see, in 1965, 1993, only the ilioinguinal. Then you can see these approaches in modified stupa, and then 2016, 2017, we are having more article are modified stupa approach plus pararectus approach. So what are the advantages? Now again, which one? Through ilioinguinal approach, the green one is actually you can see, while the blue one is what actually you can palpate the columns. Again, it's the same approach as you can see. What you can see with the ilioinguinal approach is this, the blue one. So over here, the stupa, as you can see, if you utilize the lateral window with the stupa, you can have more approach. Similarly, with the pararectus approach, you have approach to this much of the interior. So this what are the advantages of each and every? So it's a chart. Most, as you can see, ilioinguinal is the most common surgical approach. Modified stupa is a direct visualization of the medially displaced quadrilateral surface. And pararectus is actually higher level of pelvis. Disadvantages, again, ilioinguinal, external iliac neurovascular bundle injury, modified stupa obturator nerve injury may be, it can be injured, and pararectus may be limited in obese patient in those ways. So each one have, but my advice is for everyone is to have mastered this ilioinguinal, and once you have sufficient cases, then you can practice, you can have modified stupa, and you can have pararectus approach. Now, since in the last one of the slides I've shown various studies, so that was up to 2018. Now when I search the literature, so modified stupa is gaining more confident. Surgeons are more confident now. We have met this randomized control study, a good study, and it says it prefers modified stupa with other, keeping in mind the reduction. Similarly, this another Chinese study, a systemic review, rather a meta-analysis, it also it prefers this modified stupa approach for this interior column and wall fracture. Similarly, again, another study, I mean, you can find many studies now. So this approach is now, personally, I don't have any experience with this approach, but literature support, and not only, again, it's another study, again, it's a systemic review, and they have rather proved in the literature that the reduction is good with this modified stupa rather than the ilioinguinal with other approaches. And I'm happy that we have surgeons. Umair is doing a nice job, and this is a recent article of his published in JPUA and modified stupa, and which he has 52 patients. So we expect that this approach, and we have some local literature on this, we are not far behind. And with this approach will also be popular with the passage of time, and more orthopedic surgeons will be able to practice this and share their experiences with us. Thank you.
Jazakallah. Thank you, mashallah. Your presentation was very enlightening. A lot of literature being referred. Dr. Wazir, probably his presentation would be ready by now. Saad, can you kindly put on Dr. Wazir's presentation?
Yes, sure, sir. Dr. Wazir, please unmute your mic.
Yes, I have.
Okay. So have you seen the screen?
Yes.
Yes,
Okay,
Yeah,
please start.
yes. My topic is indications of the surgical interventions. Next, please.
Saad, you have to move the slides. Okay, so be attentive kindly.
This is the anatomy. Yes. Next. This is the anatomy. Please, next. There are three factors which are to be considered for operative indications: patient factors and fracture factors or expertise available. Next, patient factors we consider are the age, pre-injury activity, medical comorbidities, associated injuries, and functional demands. Next, operative indication. The goal of the surgery is to accurately restore the anatomic configuration of the joint surface, as well as congruence and stability of the joint, while avoiding the complications. Next, there are two main things which we have to be considered for surgical interventions: instability and incongruity. Next, instability usually occurs in the posterior wall fractures, and it is less common in the anterior. And it may be central if the large fragment of the quadrilateral plate is fractured. Next, and hip joint instability and incongruity is the main indications. Significant displacement of more than 2 mm of weight-bearing dome on any three standard X-rays, or posterior wall fractures involving more than 50% of the posterior wall, or incarcerated bone fragments in the joint. Next, and lack of the secondary congruence, displaced associated femoral head fractures, and injury to the ipsilateral knee, and the polytraumatized patients. Next, incongruity. The curve of the femoral head should fit exactly into the dome of the acetabulum. Mata has recommended use of roof arc measurements to measure incongruity. Next, roof arc angle. What is this? Angle between the vertical line through femoral head and line through the fracture. Helps to define fracture pattern stability. And it is considered stable if the fracture line exists outside the weight-bearing dome of the acetabulum, defined as more than 45 degree on AP obturator and iliac oblique views. Next. This is the lines. Next. And timing of the surgery, we should delay for 3 to 5 days advisable to allow patient general condition to stabilize. Next. And the indications for emergency open reduction and internal fixation. If there is recurrent hip dislocation following reduction despite of traction, or irreducible hip dislocations and progressive sciatic nerve deficit, or there is associated vascular injury, or there is open fractures and ipsilateral femoral neck fractures. If these are the conditions, then we have to do emergency open reduction and internal fixations. Next. And these are the non-operative indications for there is lack of the time. So I will finish my presentation on this point. Thank you.
Thank you very much, Dr. Wazir. Your presentation was very concise and quick. You have actually explained a lot in the bullet points, all the indications. Jazakallah. Okay, now it's my turn to present my presentation, and it's about posterior wall fractures and posterior column fractures. I'm going to quickly go through. Okay, I hope you all can see my screen.
Yes, sir, we do.
Okay. Wall and column fractures of the acetabulum is the one which all average orthopedic surgeon are treating day in and day night. We would see that in the classification system, it can occur separately or in combination. Posterior wall fractures by definition are portion of the retroacetabular surface and variable segment of the articular cartilage, while the posterior column fracture is the fracture line which passes through the posterior half of the iliac bone, including the sciatic buttress or the posterior half of the acetabulum and the ischial ramus. So the type of injury or the type of fracture, it depends upon the quality of the bone, the force which has impacted, that is the impact force, and the position of the femur in relation to the acetabulum. And because of that variable position, we can have different type of posterior wall or column fracture. The fracture can be completely posterior, or it can extend superiorly or anteriorly to a variable degree and a variable combination. And because and as the site of the fracture is there, so the approach to the fracture depends upon which segment is involved. So indications are usually, as Dr. Wazir has rightly said, that there are two main indications. One is incongruity and the second is instability. And to assess the instability, examination under anesthesia is a standard way whenever we are going to operate for these two fractures. So radiology, Dr. Irfan Qadir has explained that for posterior wall fracture, Gould sign is one of the pathognomic, and similarly the impaction, the marginal impaction is the Gould sign signifies the marginal impaction. To see the posterior wall, we have to get along with the X-ray AP, we have to get obturator oblique view, and to see the posterior column, we should do ilial oblique views. The CT scan these days is gold standard, and we can very well see the sagittal, the axial, and the coronal images, which show different fractures, which Dr. Farkader has very well and nicely explained. So coming to the approach, so the standard approach to the posterior wall and posterior column fracture is the Cocker-Langenbach approach, and we are all very familiar to it. It starts with the femur, the greater trochanter, and then curves posteriorly to the posterior superior iliac spine, and the skin, the superficial fascia, deep fascia, and then splitting the gluteus maximal muscle. Once we have done that, we reach down and we identify the sciatic nerve. And to protect the sciatic nerve, we actually dissect the obturator internus muscle along with the gemelli, and we retract it posteriorly so that the sciatic nerve is protected. By doing that, the retroacetabular area is completely visible, and then the fracture can be treated through this approach. But if the fracture line goes more anteriorly, ज़्यादा आगे की तरफ अगर fracture line हमारी जाती है, then sometimes it is difficult because of the gluteus medius muscle to approach that area, and for that we have to do some modification in our approach, and that should be done by seeing the fracture line preoperatively, and it is part of the preoperative planning. So the standard Cocker-Langenbach goes backwards, while in modified Gibson we actually extend the approach, the incision straight upwards, and similarly the split of the gluteus maximus is also a little bit anteriorly, and rather than putting the muscle into a lot of tension, we do a modified Gans osteotomy, in which the attachment of the gluteus medius and the vastus lateralis are elevated in one piece. So by that we will be able to have more anterior access to the iliac bone. So sequence of fixation will be, the posterior wall is always, as with all acetabular fractures, that you have to distract the joint and remove any incarcerated fragment, a reduction of the femoral head dislocation if it is not achieved in a closed fashion, then reduction and stabilization of the marginal impaction, and then the reduction and fixation of the posterior wall and column fracture. So this is how Dr. Irfan Qadir has explained, and also being explained in the anterior wall segment by Faiz, that this is the marginal impaction. This is a very important factor, that we open up the fracture line, go in, reduce the fragment, and then we do a bone grafting, and then we close the outer fragment over it. And for reducing the posterior wall fracture, we can reduce it with the pointed reduction forceps, or we can use the pelvic clamps, and then these can be reduced and can be holded with leg screws. But for putting screws in the posterior wall fracture, this is very, very important, that where we are putting our screws. So we must try not to be very, very near to the joint. And if we are starting more medially, then our direction has to be away from the joint to prevent the intra-articular protrusion of the screw itself. So after putting the screws, we can actually apply plates. The plate has to be convex posteriorly, and the direction of the screws which we put through the screw through the plate has to be away from the acetabulum. Okay, then coming to the posterior column fracture, this is one variety of the low posterior column fracture. We have to go through the Langenbeck approach or the otherwise, whatever suits us. It depends what kind of fracture personality we are dealing with. So we open the fracture, clean the fracture area, and obviously because there are a lot of hamstring attachment on the ischial tuberosity, so it is difficult to manipulate these fractures. For that, there are various ways of reduction. We can use Sean pin into the ischium, and we can use bone hooks or pointed reduction clamp or Farabaugh or junk block tooth reduction forceps for reduction of these fractures. So once the fracture is reduced, it can be fixed preliminary with a K-wire or with a leg screw, and can be supplemented with a single or a double plate depending upon the profile of the fracture, profile of the plate you're using. Similarly, we can also use a retrograde posterior column screw along with a single plate, and we can also use an antegrade posterior column plate if, for example, we are dealing with a transverse fracture and we are dealing with some comminuted fracture in which posterior column fracture is part of it. So I will thank you very much. I've tried to finish my presentation in time, and the questions can be answered in the chat box. Jazakallah. And I would ask Dr. Umair, mashallah, he's an emerging, budding, and very good surgeon we are having in our age group. Mashallah, Umair, I think you start with your presentation without taking any more time.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone, all my dear colleagues and seniors. I hope you can hear me clearly, all of you.
Yes, we can hear you clearly, and your presentation is also visible very nicely.
Okay, so I have a very interesting topic on my hands today. That is the transverse fractures of acetabulum. And the level of difficulty has been set with the target audience of young surgeons and those aspiring for their exams. I am working as assistant professor in the Department of Orthopaedics and Spine Surgery at Gurki Hospital. A transverse fracture by definition divides the hemipelvis into two portions through some part of the acetabulum. These fractures are 7.5% of all the acetabular fractures. And along with the T-type fractures, these fractures carry the worst prognosis. Although on the radiographs, they may appear to be very innocuous or benign types, but because they are generally caused by high shearing forces, in general, these fractures do not have that good prognosis. Posterior wall is frequently involved with them. In a transverse fracture, this is important to realize that there are two main fragments. One is the iliac fragment, and the other is the distal ischiopubic fragment. And this ischiopubic fragment is normally displaced laterally and also rotated in the coronal and the sagittal planes around the pubic symphysis. These fractures are very variable in terms of their obliquity, orientation, the sagittal level of dome involvement in multiple planes. And all of these characteristics are very important in both in terms of their treatment as well as the prognostic outcome. Most of these injuries are caused by direct trochanteric impacts with the head imploding all the way into the acetabulum. As you can see this horseshoe-shaped weight-bearing dome, and the fracture planes can be very variable, and they can be superior or inferior, anteriorly or posteriorly, depending on specific types. Now also you can see that the level of involvement in the cartilage fossa and the weight-bearing dome can be variable. In the judeointernal system, transverse fracture is considered as an elementary type, but its other variant that associated with the posterior wall is considered an associated fracture type. In AO classification, they are considered partial articular fractures 6-B1, and they're sub-classified according to their sagittal level of tactile involvement. And the transverse fractures, this concept is very important because it has a bearing on the way we treat them. In the infratectal fractures, the fracture line passes way low down through the cotyloid fossa, well away from the weight-bearing dome. And so the major part of the dome remains intact with the ilium, and it imparts congruity to the remaining joint. So most of these fractures can normally be treated conservatively, non-operatively. In juxtatectal fractures, the fracture line passes a bit higher, just close to the rim of the acetabular dome at the upper part of the cotyloid fossa, and passes through both the anterior as well as the posterior wall. These fractures are higher up, and normally they are treated operatively because they involve a significant part of the dome. And then the last and the worst variety of all these is the transtectal fractures. These fracture line, the fracture line passes right through the center or close to the center of the weight-bearing dome roof of the acetabulum. And so the portion of the acetabulum that remains, the portion of the dome that remains attached to the iliac wing is very small. And these fractures, normally carry the worst prognosis. Well, the general indications for fixation and transverse fractures is similar to the general concepts of acetabular surgery. However, the tactile level of involvement is very important, with transtectal and the juxtatectal fractures being more important in terms of operative fixation. The concept of dome displacement of more than 2 millimeter and Mata's roof arc concept is also important, and we all are pretty well versed with them. And an important finding which I frequently use in my calculations is the CT subchondral arc. As very rightly said earlier, that 3 millimeters axial slices are used for the CT scan of acetabulum, and also they're in 3D reconstruction. So if the CT subchondral arc, this is the part of the dome that is totally free of any fracture line. If it is more than 9 to 10 millimeter, normally you can treat these fractures non-operatively. And this roughly collaborates with the infratectal part of the transverse fracture. Transverse fractures, they're very tricky in terms of the approach, the way you have to treat them. If you choose the wrong approach for them and you end up opening from the part that didn't actually need the direct buttressing, and the main displacement and obliquity is on the opposite side, then they can be very difficult to reduce and fix. So the tactile height, obliquity, and the displacement and rotation is very important. These fractures can be fixed through an anterior approach, a posterior approach, or combined approaches may be required in certain scenarios. The anterior approaches we all know, ilium-guinal, the modified Stopa approach, and the posterior approach is Cocker-Langenbeck. Many of these fractures can also be fixed percutaneously if they are amenable to fixation, particularly in younger patients with relatively minimal displacement and also very elderly frail patients. Posterior approach is more commonly used for them. A very important addition in the approaches for transverse fractures is the use of trochanteric flip osteotomy and use of surgical hip dislocation. Particularly, this is important for transtectal fractures where very high involvement of the dome. There's a few of the tips and tricks for the reduction and fixation of these fractures. First, I'll be discussing the reduction maneuvers through the posterior approach. We all know that through the Cocker-Langen approach, we have this area of exposure all the way from the upper part of the greater sciatic notch to the ischial tuberosity. And also very important is this digital manual palpation of the quadrilateral surface through the greater sciatic notch. One way to reduce them is to use, first of all, one should pass a shank screw with a T-handle or some other contraption into the femoral head so that the ligamentotaxis can be used to some use as an advantage for reduction. A shank screw is passed into the ischial tuberosity. One way is to control the rotation of the distal fragment is through using this hook through the greater sciatic notch, but one has to be very careful because the gluteal neurovascular structures and sciatic nerve is just lying close by. Another good technique is that if the geometry so allows, we can use an asymmetric pelvic reduction clamp through the greater sciatic notch. And this is what I very commonly use, where we pass a shank screw into the ischial tuberosity, and then the posterior compression and fine reduction can be achieved with the help of this Jungbluth clamp. This is a screw reduction clamp whereby you can pass screws in the posterior, in the proximal and the distal fragments. Not only does that allow for compression, but also fine readjustments for reduction. After having reduced the fracture posteriorly, it is important to first fix the pivot of the fracture, that is the anterior column. And in a posterior approach, the other column which we fixed indirectly is called NVC, the non-visualized column. In modern acetabulum surgery, to decrease the mobility of the patient, it is important that we are well equipped to fix the opposite non-visualized column percutaneously or through a minimally invasive approach with simple screws. The starting point for this anti-grade anterior column screw is about 3 to 4 centimeter above the dome of acetabulum, just behind the gluteal ridge. And this axis, the screw is then passed in alternating pelvic inlet and obturator outlet views. This is a topic for another day. After fixing the anterior column, if the geometry and the bone stock so allows, one should pass a lag screw into the posterior column. And this lag screw then must be neutralized with the neutralization plate. Normally, I apply, in such transverse fractures, I also apply 2 plates to increase the strength of fixation. And normally, these fractures are frequently associated with small posterior wall fragments. They can also be buttressed through a separate plate. This is very critical. In a posterior column reduction and fixation in a transverse fracture, it is important that your plate is over-contoured. Generally, the plate is under-contoured for posterior wall fractures, but for posterior column, the plate should be over-contoured so as to apply compression to the anterior column. Otherwise, it will open up like this if the plate is not contoured properly. This is one example of one of the case. It was a combined ring and acetabular injury. It was a transverse fracture. It was transtectal, and there was small posterior wall fragment as well. But you can see that there is buttressing of both the posterior column and wall, and also an anterior column screw has been passed. And these are a few of the tricks for anterior approach. Over the time, I've seen that anterior approach is also very good for transverse fractures, particularly in the cases when the fracture obliquity as well as displacement is more anteriorly. And also there is some element of comminution. An additional advantage is that you can directly buttress the quadrilateral plate if there is any residual displacement. This is the construct that we use. There is a contoured plate along the pelvic brim with 2 or more screws passing into the posterior column, either through the plate or separately away from the plate. And these are the reduction maneuvers that can be used anteriorly. I use the modified stoppers approach for these transverse fractures. And after direct palpation of the quadrilateral surface, and we gently create space with the help of Cobb's elevator. And after putting away the obturator internus muscle, you can put this hook all the way into the ischial spine through the AIP approach. And you can help maneuver the fragment back into its reduction. In fresh injuries, a very good amount of force can be applied and reduction is easily achieved. You can also apply compression or further reduction force along the fracture line with the help of this pelvic reduction clamp. Even a Weber's clamp can be used if the geometry allows. And this is one of my examples for the fracture. You can see in this fracture, the involvement, it was a juxtatactular injury, and the involvement of the anterior column was more obliquely superior in the anterior plane. So I decided to go through the anterior approach. This suprapectineal plate was applied through AIP, and the posterior column was fixed through a small lateral window using the antegrade posterior column screw. Thank you. If any of you have any questions for this.
Thank you very much, Umair. Mashallah, your work is, we are seeing in the pelvis forum, mashallah, you're doing very nice work, dealing difficult fractures.
Thank you for your comments.
Now we are almost finished with the presentations, and we are only with 2 questions now. If the panelists, we can actually finish this presentation in interest of time, and we can actually skip the question answer session. There were 2 scenarios, but we can actually skip it, and we can finish the webinar with thanks. If there is any opinion, Dr. Masood Umar, kindly you can actually guide us. Should we skip and finish the webinar? What is your opinion? Dr. Kazim is also here.
I have to join another meeting at 5:30, so I'm already out and just about to say goodbye. But before I say that, I think very nicely conducted. And I hope panelists, the participants have had some good and useful take-home messages. It was a pleasure to be here. Thank you.
So I would conclude the session with your opinion, and thank you very much for all the panelists who have prepared their presentations, obviously, and present them very well. The subject obviously is very vast, and I do understand that this vast subject cannot be conveyed in a very short time, but we have tried to do so. Those attendees who have attended the presentation, I hope that this webinar would have increased their knowledge and would have added to some concepts. There will be a feedback form. I would request that Saad will send all of you a feedback form to fill them with honesty, and if there is anything from our side which you didn't like and you want that we should improve, that will really help us out to improve our presentations. So I would conclude this session. Professor Sayyid Amir Jalil Saab is driving. Sir, is that okay?
Thank you, Nasir. Yes, it was very good activity, and there was just so much learning opportunities with these lectures and your field discussions. Even though I am driving, but I have to be like to remain in the webinar as well. So, if the pandemic allow us, I will plan to do a similar workshop in the future, inshallah.
Okay then. Okay. Thank you all. Thank you, Faiz Bhai, Rajan Khan Saab, Dr. Muhammad Hanif, Dr. Umair, Dr. Kazim, Dr. Wazir, all of you. Thank you very much for joining us.
Sir, can I have a liberty to take a group photo of the panelists, what we have now? So I request all of them to open their cameras so I can click a group photo for them.
Sure, you have a lot of liberties.
Thank you so much. Irfan sir, want to say something? Dr. Wazir, can you please? Thank you.
Your mic is
Dr.
off.
Hanif. Dr. Mehroz, can you please open your camera so I can click a photo? Dr. Hanif, I request you also to please open your camera so I can click a photo. Over to you, Dr. Irfan, if you want to say or add.
It's okay. I just, I'm looking smart.
Yes, you are.
Okay, you can take a picture if you like.
Thank you, sir.
ये आपकी पिक्चर इतनी बड़ी क्यों आ रही है? सबकी छोटी-छोटी आ रही हैं.
I don't know actually.
मैं शैतान हूँ.
Okay, sir. Say I just can say cheese.
Cheese.
Paneer.
Thank you so much, sir.
Thank you, Saad. Thank you, everybody. Nice
Thank you,
having these talks, and it was very informative for me as well. And hope we will continue these sort of webinars in the future as well. Thank you very much.
Thank you, sir.
Thank you.
Hafiz.
Thank you. I want to say thank you to Saad for their extensive work to conduct this webinar as well. And thank you. Assalamu alaikum.
Thank you, sir. Hafiz.
Allah Hafiz.